Very much for inviting me here to. I'm a Menopause Society member as well. So I'll just take you through a little. I think many of you here would have heard this talk before, but I would just take you through a bit of anatomy to understand the common problems that happen in breast during menopause. So the anatomical structure of the breast shows a great diversity. It's a very dynamic organ, like the bone, I should say. It keeps changing with every menstrual cycle, and relative proportion of the basic breast structure, which includes the fibrous tissue, the glandular elements, fat, and the linear densities, all of this keep changing within the same breast at the same time, and also at different periods of time with an individual over time. So this is important to understand this anatomy because the density of the breast, particularly for us to not to miss certain problems. So this is the functional unit of the breast. This is where all the changes that happen, and what we call as the terminal ductal lobular unit. So this is, you have all these little ductules and the acinar tissue which end up in ducts that all join to form the main ducts that empty into the nipple. There are about 15 of them, 8 to 15 of them that empty into the duct. It's like the branches of a tree, really. So with every menstrual cycle, there is proliferation, that is new TDLUs that are formed, and with menstruation, some of these involute, and then the cycle keeps repeating. So in the early reproductive age group, we find a lot more TDLUs that are formed. So there are proliferative changes that are more likely in the early age group. But with involution, with gradual age towards menopause, with lessening of hormonal influence over the breast, the proliferative components becomes less and less, and involution becomes more. When the TDLUs disappear, that is when the breast becomes more fatty, and all the so if you see, the involution happens from inwards to outwards. That's why relatively the inner quadrants are flatter than the outer quadrants. If you see, this is a CC view, and this is the outer quadrant when the glandular tissue persists, and the inner quadrants becomes more fatty, because that's how the involution progresses. And if you see the MLO view, from below upwards, involution happens. So here it's more fatty. So this is more important surgically for us to, when we excise breast lesions. And so this is how the breast looks if you do a mammogram in a very young woman, because it's full of glandular tissue and it is all white. And that's why we do not like to do mammograms in very young women, because it's not productive. One, two, it exposes young breast TDLUs to radiation. So after the after the age of 40 towards menopause, the glandular tissue disappears and it becomes more fatty like this, which is why it's useful to detect cancers. So the common problems that you see in the menopausal age group is breast pain. So breast pain is not hormonal in this age group, obviously, because all the hormonal influence has ceased, and it's more due to muscular pain, and it's all referred pain, generally from, just like how you have referred pain from the neck down to the arm, you can have referred pain from the neck down to the breast as well. So this is often musculoskeletal in origin, so accordingly it has to be managed. The other common problems are breast cysts. There are varying types of cysts, which we'll just show now. And duct-related issues can also come around the age of menopause. And breast cancer is obviously the one thing that we don't want to miss. So like I said, the involution happens. What happens when you, with age, the involution is not proportionate. It's disproportionate. And the ductules, the terminal ductules involute first. And when this involutes, this actually becomes a linear structure without any lumen. And so what happens is, acinar tissue here lining this terminal ductal unit keeps producing the thin fluid that normally gets, you don't see it as a discharge. It gets absorbed along the way. That keeps distending, and as it keeps distending, it forms these fibrocystic change, and when there is a sudden accumulation of a lot of fluid, like it forms a tension cyst. So these are all the changes that happen here, are all in the younger reproductive age group, like adenosis, blind duct adenosis, sclerosing adenosis. These are all changes, what we call as fibroadenosis or fibrocystic change, occur in the younger age group, and these are all a group of aberrations called ANDI, and this happens in the older age group, the fibrocystic change and the big large cyst. So this is how it looks histopathologically as well. So it's not a disease really, it is more a change, and this is a frequent cause of lumps in the perimenopausal age group. And the most important thing is we should not miss a cancer in the pretext of a fibrocystic change. So that is why evaluating this becomes important. And so if you have a large cyst, like what I suddenly a lot of fluid filling up, like for example, you can have Bartholin cyst with fluid filling up very suddenly. So something like that, equivalent of that in breast. So suddenly there is a fluid filling up and that produces a large mass which wakes up one day with a big tender mass. And that's a tension cyst which look like this. It's a clear cyst. And this just needs aspiration. There is no role for cytology of this aspirate. Then you can have cysts that you incidentally pick up on screening, which is, she may not even notice it. This is a lazy simple cyst. It's flatter, it's compressible. This does not cause pain, and this does not need any treatment. Sometimes they are lipid laden, so you see a fluid level and a shifting level. And sometimes they present with inflammation. So if you see a pericystic thickening like this, so this will come with pain. So this needs just emptying. Sometimes if it's pus, you could send it for culture and treat her with antibiotics, but generally just emptying the cyst will suffice. There's generally no need for antibiotics and no need for excision, definitely. And you find cysts with thin septae like this. This again can be ignored. But if you find a cyst with a thicker septae, this obviously needs to be investigated further. This could be a cancer lurking in here. So that should be investigated. And obviously a growth within a cyst needs to be biopsied. It could be a papilloma or a cancer. The other problem that we commonly see in the menopausal age group is nipple discharge. Of course, this can occur in any age group, but we see this more commonly around the menopausal age group. So many of them are clinically non-significant, something that is bilateral, something that is multiple and happens only on elicitation, and the color ranging from greenish to brownish. Patient on, obviously this age group may not be on OC pills, but some form of menopausal hormone replacement therapy. And patients with duct ectasia. So this ducts generally have a myoepithelial component because its job is to contract and eject milk. So this myoepithelial component with age gets involuted as well. And because it's involuting, the duct actually stretches and it doesn't, the contractility is lost. So therefore the normal secretions that are produced just get retained in the duct and get stagnated. So this is an ideal culture medium for bacteria to grow, and that actually could develop periductal mastitis, especially in smokers and in diabetics. So what is surgically significant? Something that is unilateral, that is spontaneous, even without elicitation, it soils the clothes. And if it's single duct, usually that means something is growing within that and it's discharging. Something that is persistent, it's serous, serosanguinous, or obviously bloody. So these are things that have to be evaluated to rule out a papilloma and a cancer. So nipple discharge cytology often is wasteful, does not really help. What could help is a clear, good ultrasound. So we obviously, and a mammogram. So we look for an intraduct papilloma or a cancer. Now these lesions are very difficult on histopathology. At least the diagnostic core biopsy is very difficult to diagnose because these tend to fragment, and then with the fragmentation that's happening, the pathologists have very little tissue to tell us clearly whether it is papillary cancer or a benign papillary lesion. So they often give it broadly like a papillary lesion with or without ATPR. So we have to excise it to get further confirmation. So in this age group, we are not worried about preserving lactation, so we would do a total duct excision. And if we are reasonably sure that it is a papilloma on radiologically, we could do back-guided excisions to avoid an open operation. So if you see this, there is a lot of duct dilatation here, and there is some debris within the duct. So how to differentiate a debris from a lesion that you see actually a rim of normal duct tissue. It's not attached to the duct wall. So if you see this in a cross section, it usually means that it's a physiological dilatation with duct debris. And sometimes when it gets inflamed, so you see dilated, it's a surrounding inflammation, and if you put a Doppler there, it actually lights up with because of inflammation. So here you see that there is something visibly growing inside and extending into the duct. This is obviously a papilloma. Here again, you see it attached to the wall, and there is a blood supply into the lesion. So therefore, that is also suspicious of a growth within the lesion. And here also you see there is there is a vascularity within the duct without any signs of inflammation. So these could be papillary intraductal papilloma, intraductal papillary carcinoma, so it has to be appropriately dealt with. The other common cancers that we all issue that we all dread dealing with is a cancer. We don't want to miss a cancer in this age group. So this is the cancer registry from India. If you see, breast is the single most common cancer. And the reason we have nearly 50% mortality is because they present at an advanced stage. So the idea is to pick them up early. So stage 1 and 2 cancers have a very good overall survival with good quality of life with all the advances in treatment now. So this is one such screen detected lesion that looked like this on ultrasound. So obviously a small lesion that we excised, and we were able to preserve the breast and good quality of life as well as achieve a cure. So generally postmenopausal breast cancers, the incidence increases with age, and over 70% of them are going to be ER positive. So this has an implication in the lady's quality of life, because if it's an ER positive cancer, we're likely to use either estrogen blockade, receptor blockade, or estrogen aromatase inhibitors to prevent estrogen formation. So with the ovarian source ceasing, there are extra ovarian sources that produce estrogen by the process of aromatization, peripheral estrogen production. So this aromatization will be inhibited by the aromatase inhibitors. So there'll be zero estrogen. So this obviously leads to consequences because of lack of estrogen, and that is something we have to deal with together to help the patient achieve a good quality of life. So we don't like any estrogen supplements in estrogen receptor positive patients. So this is something we have to work out a solution. And with tamoxifen, of course. So we generally use tamoxifen in patients who've had a hysterectomy in the menopausal age group. So between tamoxifen and aromatase inhibitors, there is no advantage of overall survival, but the disease-free survival is definitely better with aromatase inhibitors. So that is a drug of choice. But where there is a compromise in quality of life, then we actually prefer tamoxifen, because tamoxifen does not cause the total estrogen suppression. It actually acts at the receptor level, and it's like a sound, and it does a competitive blockade. So there is some amount of estrogen in the body, but the receptor is blocked, and therefore there is no total lack of estrogen. But what it does cause is there is a risk of DVT, and there is an endometrial cancer risk, about 7%. And also there's a lot of benign endometrial issues and subendometrial hypertrophy. So they often come with endometrial thickness. We end up over investigating because the guideline says anything more than 5 millimeters, investigate. So they end up having more than one procedure with hysteroscopy and biopsy. Very stressful. So when there is a hysterectomy, then I give them tamoxifen. But otherwise, then we go with aromatase inhibitors. If they are not able to tolerate aromatase inhibitors, then we go on to tamoxifen. So coming to the issue of screening. So in India, should we focus on clinical breast examination or with mammography? So with age and wisdom over practicing over a decade and a half, we've now come to the conclusion that it is in India, population-based mammographic screening is not going to be feasible, and it's not going to be productive. The mammographic screening debate per se is continuing, and worldwide people are thinking and rethinking about it. Switzerland as a country has come out of a national screening program. They've made screening voluntary, so they do not have a screening program. It'll be interesting to see the incidence and mortality from Switzerland 10 years, 20 years from now, and that will guide us for future regarding mammographic screening. But the West still continues to screen. In our country, I think we should invest on a focused clinical breast examination. And that is where the primary physician and the obstetricians and gynecologists play a very important role, because most of the patients are then going to be seen by them. Clinical breast examination should be included in every examination. And opportunistic screening, of course, should be encouraged. High-risk screening should be mandatory. And there is a lot of confusion with imaging. Should we do a mammogram? Should we do an ultrasound? So in the menopausal age group, definitely ultrasound is not the primary modality. It has to be mammogram combined with an ultrasound wherever required. And again, there is a lot of confusion with the BIRATS terminology. The BIRATS was meant for standardization of reporting with a clear definition of criteria. So this is to help clinicians decide appropriate course of action. And so the onus is on the radiologist and to an extent us clinicians to understand the standardized terminology. So this is important in us to help us decide which needs what course of action. So any suspicious lesion have a low threshold for biopsy, because this is one age group where we do not want to miss a cancer. And again, repeatedly I say avoid an FNAC, because with FNAC we often get inadequate smears and the material is not sufficient for a clear diagnosis, and a lot of information is lost, and a false negative or a false positive both are dangerous and has serious implications, medical legal implications, and it also causes unnecessary anxiety. So a guided core biopsy of the breast lesion is the gold standard for diagnosis. So with this, I will conclude, and I'm happy to take any questions in the panel.